Hariharan, Sameer, and
Yes, sir. Yes, sir.
Manoharan, sir.
Okay,
sir.
yes, sir.
Say we are ready.
Sir, we can start.
Yes, sir.
Hello, everyone. Good evening, everybody. All of you know that our website regular lectures are going on. Today we are having live session about the peripheral vascular disease examination, which is very, very important for postgraduate, undergraduates, and everyone. Very, very common entity which we come across in day-to-day surgical OP, and with the admission, of course, maybe managed many times by the vascular surgeon. So for this live session, we have got here with us a special faculty guest, Professor V Manoharan, sir. He till welcome you, sir. Sir was till last few months he was head of the department of Manakula Vinayagar Medical College and with Puducherry for long time, maybe nearly more than 8 years. He was head of the department, running the department. Now he is become professor and unit head in the same college. Sir did his MBBS from SRMC Bangalore University, then went on doing MS in General Surgery Stanley Medical College. After that, you hear from the colleges with the academic session in the Department of Surgery. He was a vast academic knowledge. He was examiner for MBBS, MS, DNB for different universities across the country. And he has come to our college also many times. Our university, Market University, also come as examiner. And he got many international national journals in his name. And he is currently 66 years young, not old. I would use old, sir. He is still young, very charming, very affectionate personality. I know, sir, very well. Very, very good in giving hospitality and very good teacher and very an academic thinker. And another thing from our side, why my side, because he daily sends very good quotations, knowledge quotations early morning. So if any delay from his quotation, we'll be annoyed. We get sir has not message. Even though we don't respond, every daily he'll be sending very good, beautiful messages for us with quotations. Thank you, sir, for that. We are always waiting for your messages. So that is here, sir. We welcome you for our discussion. Please get involved. Your vast knowledge in the academic thing. So we all welcome Professor Manoharan, sir, for this session. Thank you, sir. And today's presenter, sir, from G. Sameer Nanda, final year undergraduate student from the Manakula Vinayagar Medical College, Puducherry. Sir's students. And Hariharan, again from the same college, final year student. They are presenting the case, disease, with the guidance from the sir. We'll have a interactive questions about the peripheral. This is very, very important for the exam. Welcome both Hariharan and Sameer Nanda, and welcome to all students across the country who have joined to the YouTube now and later period whenever they join for this academic session. We can learn properly basics as a clinical knowledge, even like similarly like a clinical examination in the exam. So we'll not wasting much time. We'll continue that. Before that, I am myself Dr. Sriram Bhatt. My books are there. This is the website academic channel. I welcome everybody. Sir, we'll directly go through the presentation.
Yes, sir. Yes, sir. Please. Yes, sir. Please.
So with the sir's permission, we are going to discussion. Shreya, start presenting. Who is presenting? Sameer. First, who is presenting?
Yes, sir. I am presenting, sir.
Okay, Shreya, go through this one. You present Sameer. Whenever
Yes, sir.
we myself, sir may intervene. Usually
Yes, sir.
present, then we'll discuss. Okay, start presenting.
Okay, sir. So, Good morning, sir. Good morning, Dr. Sriram Bhatt, sir, and good evening, Dr. Manoharan, sir. It's been a pleasure to present in front of you, sir, and good evening to all the students presenting across the country. So we'll start our session. A a 65-year-old male named X came from. He's a retired policeman and married. Came from the Pondicherry. Next slide. And his chief complaints are pain in the left lower limb for the past 3 months and black discoloration of the left great toe for the 2 weeks. You can see that in the image. Next slide. History of presenting illness. Mr. X was apparently asymptomatic before 3 months, after which he developed pain in his left leg, which is insidious in onset, cramping type, progressive in nature, non-radiating. Initially walks to a distance of 500 meters, now reduced to the 200 meters since last 1 month, and relieved on taking a rest. Complaints of rest pain for past 2 weeks and complaints of numbness, pins and needle sensation, tingling sensation in the foot, left foot, and which is occurring on during walking and subsiding on the rest. Next slide. And complaints of blackish discoloration of the left great toe for past 2 weeks, and which initially started on the tip and progressed to involve to the half of the toe, and no history of fever, no history of blackouts or loss of consciousness, no history of visible disturbances, no history of chest pain or palpitations, no history of postprandial abdominal pain, and no history of discoloration of fingers on exposure to the cold. And past history, known case of type 2 diabetes mellitus for 25 years on tablet metformin and glypropamide once daily, and he is not on regular consumption. And is not a known case of systemic hypertension, pulmonary tuberculosis, bronchial asthma, epilepsy, and dyslipidemia, and COPD. And no past surgical history. And personal history, he consumes both vegetarian and non-vegetarian diet, regular bladder and bowel movements, and sleep disturbances due to pain on the foot since last 10 days. And he has normal appetite and no addiction history is present. No smoking and no alcoholism. And no significant family history is there. History summary: a 65-year-old male, non-diabetic, came with complaints of pain over left lower limb for past 3 months and relieved by rest initially with early signs of ischemia and now complaints of pain even at rest for past 2 weeks and blackish discoloration of left great toe for 2 weeks, suggestive of critical limb ischemia likely due to the peripheral arterial disease, and it is probably due to the atherosclerosis etiology.
Right, Samir, we'll have a little bit about the discussion about your presentation. We'll go,
Yes, sir.
go back to the history of present illness. You said claudication. What is claudication distance here? So what grade it is? What is the grading which we use? Samir? Samir, you can hear me?
Yes, sir, I can hear you. Yes, sir, I can hear you, sir.
So what is the grading? Claudication grading?
Sir, here we use classification grade 2, sir.
Grade 2. What's the name of the grade?
Sir, Boyd's classification, sir.
Broad classification. That's right. All of you should know that grade 1, 2, 3. See, rectifying doesn't come under the Boyd's grading. That is
Yes,
different
sir.
entity. Don't ever put rectifying under the Boyd's grading. Only 1, 2,
Yes,
3,
sir.
3 grading is there. Is the grade 2. Absolutely right. Now the patient is having rest pain. What is the cause for rest pain? You said 10 days rest pain.
Yes, sir. Rest pain is due to the atherosclerotic ischemia and due to the embolism. The patient is getting pain which is not subsiding even day or night to the from the past 2 weeks in the duration, sir.
Oh, that is the cause of embolism. What is the cause for rest pain in this patient?
Sir, can you repeat it, sir?
Cause for the rest pain.
So, due to atherosclerotic event, sir.
Okay, that is the you are telling etiology. Rest pain, what is the cause? I'm not asking about the etiology. Rest pain, you said rest pain is present since the 10 days. Why it
Yes, sir.
happened? Rest pain. Hariharan, why it happened? Rest pain. It is the
Because of the vasospasm in
okay. It is a
because
vasoconstriction
there is a,
nerve involvement, the crying
just
of the dying nerves.
Oh,
When
because of
nerves are involved,
vasovasorum is involved, so the blood supply is reduced.
this
So
is,
the
this is the cause for rest pain. The
vasovasorum is
crying of the dying nerve. So
yes.
Yes, sir.
okay. Then family history, you should have little detail about family history. How many members are there? How many siblings are there? And how many children patient
Yes,
is
sir.
having? 65-year-old. So that
Yes,
is diabetic. Little more details since how long he is there, whether he is going when
yes, sir.
things are okay, and other thing whether he had any time chest pain. All those things you have to confirm. Okay. So
Yes, sir.
sir, over to sir. Sir,
yes, sir. Initially, Samir,
Yes, sir.
initially patient, you said rest pain is since how many days?
Sir, from the past 10 days, sir.
10 days only. That means what does it mean to you?
Sir, initially, the condition is increasing, sir. Like patient is progressing towards the gangrene, sir.
No, no. Initially, its claudication distance was 500 meters.
Yes, sir. Claudication distance is reduced, sir.
Reduced to how much?
Uh, 200 meters, sir.
200 meters. That means disease is further progressing.
Yes,
So
sir.
initially did not have any. Only on rest he said pain is relieved. Now
Yes,
he
sir.
says, now you say patient is having rest pain without doing anything also.
Yes, sir.
Patient is
Yes, sir.
having severe pain. So what does it mean to you?
Yes, sir. Sir, the disease is progressing, sir. Like that, patient is having more ischemia and more vasospasm in the. And this is
Vascular insufficiency is increasing. Okay.
yes, sir. Yes, sir.
You,
Yes, sir.
you use the word critical limb ischemia. What is meant by critical limb ischemia?
Sir, in the critical ischemia, the wanting of the blood towards the feet is increasing. That means patient is having losing of pulses in the peripheries, sir. So,
no, Samir, no, don't get tension up. Sir is asking how will define critical limb ischemia.
Definition of critical limb ischemia, at least signs and symptoms of critical
Basic thing we are asking it. Okay, be cool. Whatever you know, just tell Hariharan anything.
Sir, in critical limb ischemia, there will be pain which is present for more than 2 weeks. Sir.
Okay, okay. One other thing,
Second,
pressure.
sir, pain is not subsiding on any other medication, sir.
Okay, three.
then
Uh, and
Acute
pain
pressure.
pain will be present on both day and night, sir,
Okay,
and which is relieved on gravitational pull. If a patient sits on the dependent position, he will be relieved slightly, sir.
and gangrene ischemic ulcer and
Yes,
ankle
sir.
pressure less than 50, toe pressure less than 30. So that is the definition. If somebody asks what is critical limb ischemia, this is what sir rightly told. So you have to tell these things. Pain,
Yes,
persisting
sir.
pain, not responding to any NSAID for 2 weeks, then gangrene ischemic ulcers, then toe ankle pressure less than 50, toe pressure less than 30. Correct, no sir?
yes, sir, yes, sir. Yes, sir. Thank you, sir.
So these are the things you have to know. So you should write a little more detail about the family history and smoking. Other things you have added. If somebody is, you said it's not a smoker. If somebody is smoker, then smoking index and smoke air index and a pack air index you have to add on to that. If somebody asks that, you should know what is the meaning of that. Okay. So
And,
this
Yes,
is
sir. Yes, sir.
and Samir,
very
you said
Yes, sir.
patient is a diabetic
Yes, sir.
and he is on metformin one dose.
Yes, sir.
But usually, what we advise a diabetic with vascular insufficiency or an ulcer, what do we advise?
Sir, a strict diet control and continuation of taking the medications on properly,
What,
sir.
what type of
And
medication?
uh, usually we prefer metformin for the 3 weeks.
No,
Uh,
that is
3 weeks,
regular
sir.
regime. That is regular regime. In a surgery department, what do we advise? Preferably to have a proper glycemic.
Diabetic.
Diabetic
proper
patient.
sir, we'll advise the patient to look for the his food daily when he is going to bed, sir.
No,
And
drugs,
and
drugs, medications. We are asking about medications.
Medication.
sir, insulin, we can advise if the patient is
Choice
not
is,
controlling,
choice
sir.
is preferably, choice is preferably always
Insulin,
insulin.
sir.
Okay, your patient is on metformin's one dose only,
Yes, sir.
as per history. So what
Yes,
does
sir.
it mean to you?
Sir, his diabetes is not in the on control, sir.
Control, and that too not high. That is why what only with single dose he is able to control the
Maintain the
understand. So if he is a very high, severely diabetic, what has got diabetes to do with your atherosclerosis? Any connection?
what is the relation of diabetes and atherosclerosis? What are the risk factors for atherosclerosis? The atherosclerosis is the
There is
commonest
an
cause
increased chance of
peripheral vascular disease. Okay, then of course TAO in young individual.
So your patient is 65 years, elderly, so he is prone for atherosclerosis. Okay. Added to that, he is a diabetic also. So that adds multifold. That atherosclerotic risk will be much more there.
Increase at the problem.
classification of sounds also.
Yes, sir.
Yes, sir.
Proceed, sir. Kindly.
Sir, we'll go for examination, sir.
Yes, sir.
Samir or Hariharan, who is presenting, just go through the examination.
Sir, I'll be proceeding, sir.
Good evening.
Good evening, everyone. General examination.
Proceed.
You're not getting the slide?
Okay, sir. Yes, sir, I'm getting it, sir. Thank you. After getting the informed consent, the patient was examined in a well-lit room with adequate exposure. The attitude of the patient was sitting with legs extended, and the gait of the patient was normal. Patient is conscious, cooperative, oriented to time, place, and person. And the height of the patient was 174 centimeters, and the weight was 72 kilograms, and the body mass index was 23.7. Next slide, please. Vitals, pulse rate. It was 86 beats per minute in the right radial artery. There was normal volume, regular rhythm, and character. There was no vessel wall thickening or no radio-radial delay or radiofemoral delay was noted. Blood pressure. The right upper limb showed 130 by 90 millimeter mercury, and the lower limb showed 130 by 90 millimeter mercury in the right lower limb. The ABPU was interpreted as 1, which was normal. Left upper limb 130 by 90 millimeter mercury, and the left lower limb showed 50 millimeter mercury, which is interpreted as 0.4 ABPA, which shows the critical limb ischemia. So there's going to be respiration also. Respiratory rate, 18 breaths per minute was present, and the pulse oxygen saturation was 99% at room air, and the temperature was 97 degrees Fahrenheit, which was normal. There was no pallor, icterus, cyanosis, clubbing, or generalized lymphadenopathy or fetal edema. Next slide, please. Local examination, inspection. Examination of both the lower limbs are done. Attitude of the limb, extended at hip and knee joint. No deformity or shortening of the limbs were noted. No muscle wasting was noted at the thigh and calf region. The skin appeared thin and shiny, with loss of subcutaneous fat on the left foot. No loss of fat noted over the left lower limb, and the nails appeared to be brittle over bilateral toes. Next slide. Blackish discoloration was noted over the tip of the first toe, which was dry and shriveled in appearance, and the line of demarcation was present. There was no ulcer or foul-smelling discharge present. The surrounding skin was appearing to be normal. Next slide. The gangrenous area was cold compared to the adjacent skin. Tenderness was present on the foot till mid-foot. Surrounding skin had no edema or ulcer or any excoriations present. The capillary refilling time was about 5 seconds on the little toe, which was increased. So the gangrenous areas inspected findings were confirmed, and there was no local cryptus or restriction of movement, and there was a restriction of movement in the first toe. Next slide. There was no restriction of movement at the ankle or knee joint, and hyperesthesia was present on the skin of the border of the gang in the line of demarcation. Mid-calf circumference. In the right limb, there was 32 centimeters, and in the left limb, there was 33 centimeters. In mid-calf circumference, there was no wasting. Burgess postural test was positive. Cross-leg test, fascial test showed normal oscillatory movements. So, popliteal artery is patent, and the gait was altered. Examination of the pulses. The Rosales period showed feeble pulse in the right limb, and there was absent pulse in the left limb, lower limb. And posterior tibial pulse was normal in right limb and feeble in the left limb. Anterior tibial pulse was normal in the right limb and feeble in the left lower limb. Popliteal pulse was normal in both the limbs, and femoral pulse was also normal in both the limbs. Next slide, please. Radial pulse, the radial, ulnar, brachial, axillary, subclavian, and common carotid, and the superficial temporal artery pulses were normal in both right and left side. Next slide, please. The ankle brachial pressure index was found to be 1 in the right limb and 0.4 in the left limb. The neurological examination showed normal fine and crude touch sensations on the skin surrounding the gangrenous areas. Lymph node examination. The no inguinal lymph nodes were palpable, and the auscultation showed no bruit or hum. Next slide, please. Systemic examination. Cardiovascular system showed S1 and S2 were heard, and there was no added murmurs. Respiratory system. Bilateral normal vesicular bed sounds were heard, and there were no added sounds. Per abdomen, it was soft, and there was no swelling, and the bowel sounds were heard normally. Fine. There was no deformity or tenderness noted. Next slide, please. The case summary. A 65-year-old male who is a known diabetic came with chief complaints of pain over the left lower limb for the past 3 months and relieved by rest initially with early signs of ischemia, and now complains of pain even at rest for the past 2 weeks and blackish discoloration of the left grade toe for 2 weeks. On examination, the dry gangrene of grade toes of left foot with gangrene extending to proximal phalanx with signs of ischemia and diminished pulsations of bilateral posterior tibial, anterior tibial artery and absent dorsalis peris artery on the left side was present. Provisional diagnosis. The peripheral arterial occlusive disease affecting left lower limb with ischemic gangrene of grade 2 due to infrapopliteal arterial occlusion, secondary to small vessel disease.
Okay, wait. We'll have a discussion now, sir.
Yes, sir, please.
Right. Hariharan, what is the ABP?
Yes, sir. Ankle brachial pressure index is equal to the maximum.
How much it is critical? What is the normal value?
Normal value will be 1 or more, sir.
Okay. And claudication, how much it becomes in claudication?
In claudication, it will be 0.5, sir.
0.5, 0.6. If below 0.3, it is a critical limb ischemia. You are told 0.4.
Critical limb ischemia, gangrene could occur, sir.
Okay, but okay. Sir will ask about the details about that. There is no muscle wasting, you said. Are you sure no muscle wasting? Because ischemia is severe. Photo you have shown, no, somewhere. Photo was there, no? Photo was there.
Gangrene was present, sir. Gangrene photo was present, sir.
Okay, proximally, ischemia, there was no muscle wasting in the leg.
Generally, in critical ischemia, there should be wasting, sir. But in this case, we didn't mention that.
Then the temperature you have not mentioned on palpation. I think temperature is very crucial.
Temperature was 97 Fahrenheit, sir. In vitals, we had added.
No. Limb temperature, whether foot is cold or not, and this warmness.
Foot was cold, sir.
Yeah, this how far it is cold proximal. Very important.
Yes, sir.
What level?
What level it is? This temperature, coldness is extending. Where it became warm. That level is important, which you have not mentioned.
Above ankle, the leg was warm, sir.
Warm. After the above the ankle, leg become warm. No? Okay, that point has to
Yes, sir.
be mentioned. The line of demarcation you said it is what? It is what type of line of demarcation it is? What is line of demarcation?
Hyperemic, sir, in the gangrenous area is separated from the normal tissue
Normal tissue.
through the area of hyperemia, which is
Correct.
called as the line of demarcation.
Here it is a clear line of demarcation or unclear line of demarcation? Spreading.
Clear line of demarcation, sir.
Clear line.
Right gangrene.
If it is spreading, what it means?
In case of wet gangrene, the line of demarcation won't be proper, sir.
Spread is unclear and it becomes a wet gangrene. Muscle tenderness,
Wet gangrene.
have you checked in the calf or anywhere? Muscle tenderness. You said
Tenderness was checked, sir.
okay. Ankle joint movement.
Muscle were tender.
Ankle joint movement. You checked.
Yes, mentioned.
Yes, sir. Ankle joint movement were normal, sir.
Okay. You said capillary refilling is more than 5 seconds. Is it normal or abnormal?
Yes, sir. In the lateral abnormal, sir.
What is the normal value?
Normally, it should be less than 2 seconds, sir.
Less than 2
But in
seconds.
this case, it was greater than 5 seconds, sir.
Perfect. This is increased because there is ischemia. So
Yes.
Then pulsations will just where will examine the pulsation? Where will check the dorsal pedis pulsation?
The dorsalis pedis artery is checked lateral to the external hallucis is longer, sir. In the proximal space.
Over which
metatarsal
bone?
space, sir.
Over which bone?
Over the navicular bone, sir.
Navicular. Right. Popliteal, where will palpate? How will palpate?
Popliteal, I'll ask the patient to put the leg on 130 degree, having the heel on the bed, sir. And then I'll take my 2 hands and have my thumb over the tibial tuberosity, and I'll insinuate both of my pulp of the fingers into the popliteal fossa in the lower part, sir, so that I could feel it in the proximal part of tibia, sir.
Okay. Ideally, it should be in the prone position. This position in the supine.
Yes,
Okay. Prone position with the flexion to that relax and over the lower part of popliteal fossa. Femoral artery.
The femoral artery will be seen near the mid-inguinal point, sir, against the femur head, sir.
Not head, actually. The neck of the femur. Head is inside the acetabulum. It's over the neck of the femur. Okay. What maneuver
Yes,
will
sir.
What maneuver will do while checking the femoral artery pulsation?
I'll ask the patient to flex the knee, sir.
Flex the knee, plus the hip abduction and external rotation. Flexion,
external
rotation. Okay.
Yes,
right. So that's how then over the neck of the femur you will palpate below the mid-inguinal point.
Yes, sir.
Mid-inguinal point.
The mid-inguinal point is the line joining the anterior superior iliac spine to the pubic tubercle.
Pubic tubercle or pubic symphysis?
No, sir. Symphysis. Symphysis.
Confused. Midpoint of the inguinal ligament is anterior superior iliac spine and pubic tubercle. Mid-inguinal point is pubic symphysis and anterior superior iliac spine. So same mid-inguinal point is used for hernia examination, where deep ring is above that, whereas femoral artery is below that. So it's the same mid-inguinal point is used for hernia examination. Same mid-inguinal point is used for palpation of the femoral artery. You should have a very clear idea. Okay. Right.
Yes,
sir, over to you, sir.
Yes, sir. In general examination, did you mention about anemia?
Sir, there was no palate, sir.
No, because why that is important? Is it important?
Yes, sir, it is important.
No, though it may not be very significant. A patient who is in vascular insufficiency added to that is severely anemic. So that will produce more ischemic symptoms. So that
more effects will be producing.
So that you have to be very careful in measuring about your anemic this thing. Okay. And second thing you said, examination of pulses, you said dorsalis pedis is absent.
Yes, sir. In the left lower limb, sir.
Anterior tibial is present.
Anterior tibial was feeble, sir.
Feeble. So you should always, finding is okay, but you should always say I compared it with the opposite leg.
Compared with the right leg.
That you should mention. So this is absent. Pulse chart you have mentioned, but when you say warmth, warmth SR pointed out is very, very important point. using the dorsum of the
Yes,
hand,
sir. Compared with
above the toes, ankle. It is warm means it is equally warm with the other limb. That also you should compare. Okay.
yes, sir.
You said
Yes, sir.
paresthesia. What is this paresthesia?
Sir,
Above the,
hyperparesthesia will be seen near above proximal to the line of demarcation, sir.
okay. So muscle wasting is very, very important. Sir correctly pointed out. When an ischemic link with dorsal sphincter artery absent, definitely there will be some amount, at least a millimeter
Wasting will be present.
wasting will be there. So that measurement, in fact, in your reading, I think your left side is more than 1 centimeter more than the unaffected limb. Okay, so that is a flaw. And second thing, sir asked about muscle tenderness. Muscle is ischemic
Yes, sir.
muscles. When you try to palpate them, definitely there will be some amount of discomfort. So that is what that's also
Yes.
sign of ischemia. Don't forget to mention that.
Yeah, that is important.
Yes,
Muscle
sir.
tenderness is very important.
Muscle tenderness and temperature, this thing, and comparison with the opposite limb is very, very important.
And how
Yes, sir.
far proximally this coldness becomes warm, that demarcation is important.
Yes, yes.
So, and where
Yes,
it
sir.
is perfusion has become very low, that temperature is a very good, very important finding. You have to check the temperature at different places proximally, from distal to proximal. You have to check like this, and where it becomes warmer,
Yes, sir.
that area is very important. In phase, if you don't land with the amputation, you may have to clinically decide the level of amputation. That's why temperature is very
Yes, sir.
crucial. Okay.
In inspection, did you mention about the signs of ischemia?
Yes, sir. There was no hair loss and the skin was shiny, sir.
Did you write
And
it?
then,
Is it in the
And
present?
nails you have written higher.
yes, sir. It was there, sir. Yes, sir.
What, tell me the signs of ischemia.
So the hair loss, sir,
Mm.
and shininess of skin will be lost, sir.
Mm.
And then nails will be brittle,
Mm.
and there will be transverse ridges present.
And one more, loss of subcutaneous fat.
Loss of subcutaneous fat and muscle plateau, sir.
Muscle wasting will be seen.
Okay. What is this capillary filling time you said?
Sir, we will be compressing the pulp of the uh, digits or toes, sir.
Okay.
And we'll check for the
It will become
pallor to go off within two
It will become
seconds.
blanched, and once you remove the pressure, immediately it should be refilling. So that time only you said.
Yes, sir.
What is guttering of the vein? Have you heard about it?
So guttering of vein is the shrinkage of the veins when due to the absence of blood in the veins, sir.
Okay. So because guttering of is a feature of ischemia, because otherwise even in limb elevation, normal vein will not collapse completely. There is a partial filling will be there.
Yes, sir.
So refilling is very slow in the vascular insufficiency. So entire vein will become like a gutter.
Better on.
Typical of
Yes, sir.
severe ischemia.
So always you should mention that.
Yes, sir.
You have to mention the guttering of the vein. Of
Yes,
course,
sir.
Burger's angle in a gangrenous area, it is not necessary, no, sir.
Yes, sir. Yes, sir.
It is not necessary to do that angle of insufficiency. That is done only if there is no gangrene. Here, when there is a rest pain in the critical limb ischemia, there is no. You have to just mention Burger's angle. I have not checked because there is no. They are not necessary. It's already critical limb ischemic. Okay, you should know how to do that. Elevate, then check the angle where that blanching occurs. Okay, so that is different things in the examination, and these are the very important things which will be asked in the while presenting the case. So anything else to add, sir? Palpation.
Not for UGs, but anything more sensitive than ABPA?
Anything more sensitive than the ABPA?
TBA, sir.
Huh?
Toe brachial index. Sir.
Yeah, toe brachial pressure. Yeah. Another thing, ABPA is not by the checking pulse. You have to use the Doppler in the waveform.
Yes, sir. With it.
Okay, not just checking the pulse. That is the point you have to remember. ABPA is checked with using the Doppler. Okay. All four limb DP should be checked when you check the ABPA. These are the different points you have to remember. What is the fallacies of the ABPA?
So in case of diabetes and atherosclerosis, there could be vessel wall thickening, sir. So it will be more than 1.2, sir.
1.2. So that will be fallacies. In that situation, you have to check the toe brachial pressure index.
Including calcification.
Yeah, because of the calcification.
Yes, sir. Calcification.
So that point you have to remember. ABPI may be a short note for you people. And in the vascular case, when you present, definitely details about that will be discussed. So,
Yes.
so anything else to sir? Palpation because
That's
is it
okay.
sir?
Yes, sir. Okay.
These are the things you have to remember. So, what are the mistakes sir has pointed out or we have discussed? That should be rectified. Other diagnosis you have to write always in a proper, complete diagnosis with the side, everything.
Yes.
What the cause, everything. Of course, atherosclerosis you may have to add here. Why atherosclerosis? So, next slide, Shreya.
Differential diagnosis:
Okay.
thromboangiitis obliterans, Burgess disease, chronic non-healing ulcer, embolism, and vasculitis.
Right.
Next
Wait.
slide, please.
Now, is it possible this to be a TAO?
Uh, it's unlikely to be a TAO, sir, since
Right.
the patient is not a smoker.
The age is higher compared here, sir. Usual TAV comes in around 40 years and below, sir.
Okay, that's what.
And
It's
here we can see
it's
yes, sir.
unlikely to be TAO. And another thing you said, important thing, history-wise, you said no. Another important thing,
Not a smoker, sir.
not
Not a
a
smoker.
smoker, because it is unlikely to be seen in a smoker. So TAO,
Yes, sir.
commonest cause, of course, you have put. I think atherosclerosis is the commonest cause. In this patient, cause is
Yes.
atherosclerosis. It will come into the discussion, and you have to rule out. He is not a smoker, so TAO will not be considered. But you have to inform that TAO is a differential, but not considered here. And age and smoking. You said chronic non-healing ulcer. Why is it? What is the cause for non-healing ulcer here? Then embolism you have written. What is the presentation
Yes,
in
sir.
Agreed.
Acute onset occlusion of the
acute onset?
vessels could be a cause.
Have you asked the history of fever in this patient? Have you
So
mentioned?
there was no fever in this patient, sir.
Not there. Okay. Then you added on to the vasculitis. What are the how will differentiate from vasculitis?
So there will be autoimmunity, sir.
Okay. Okay. So, sir, about these things, they should able to explain and say it is not so. They should able to give reason, no, sir.
Yes, sir. Yes. Embolism is acute or chronic?
Acute onset, sir.
So this is acute etiology or chronic etiology?
This is a chronic etiology, sir. Critical limb ischemia is therefore more.
So embolism will not fit in.
Yeah, embolism will not
Yes, sir.
fit in. You better to should not write embolism here. TAO you can write
Yes,
and
sir.
say he is not a smoker. It is not so. Vasculitis you can write and say, but we can got enough reasons why it is not so. And but embolism better to skip in a differential diagnosis. So diagnosis
Yes,
is
sir.
etiology is atherosclerosis, which you have already mentioned. Okay, right.
Yes, sir.
Yes,
So
sir.
you should be able to justify or you should be able to rule out this condition because of these reasons. You should be able to give reasons in the
Yes,
exam why it is not so, why it is not so, like that. Okay, you should be able to
yes,
give
yes,
analytic
sir.
reason why it is not so, why it is so. Okay, right. Say next slide,
Yes, sir.
sir. Next we'll go
Yes,
to
sir.
the
Yes, sir.
Investigations.
okay.
Non-invasive methods. Doppler ultrasonography, duplex scan, ankle brachial pressure index to quantify the degree of arterial insufficiency. The ABPA will be less than 0.5, indicating the severe ischemia, and CT angiography, MR angiography, and digital subtraction angiography will be done. Next slide. Blood investigations, CBC, fasting and postprandial blood sugar levels, HbA1c levels, lipid profile, renal function test, creatinine and blood urea nitrogen, cardiac status, echocardiogram and electrocardiogram, X-ray of the foot to assess the extent of bone involvement in the gangrene. Invasive methods, angiogram will be done. Next slide.
1 minute, 1 minute.
Management part.
Wait. We'll
So
discuss.
finish the investigations and then
Discuss.
go
You
back.
said
Go back. Go back.
yes, sir. Go back. Shreya, go back.
Yes.
Okay, sir. This Doppler, you have to tell B mode duplex scan with the ultrasound Doppler. Okay, go with duplex scan
Yes,
and
sir.
Doppler. It's a B mode. B mode is what is the B
B
stand?
mode ultrasonography with Doppler, sir.
The B
Brightness mode, sir.
brightness mode. Okay, so
Brightness mode.
single word you have to use. Then
Yes.
conventional angiogram or CT angiogram. There is a CT angiogram for dynamic CT angiogram is ideal. What findings you look for?
In CT angiogram, we could find the localize the part where the embolus is present, sir.
Okay, then What findings you look for in angiogram?
So collaterals will be seen, sir.
Okay, collaterals, site of block, collaterals. Then what is the typical corkscrew appearance, especially in TO and other
Corkscrew
Ah,
appearance
yes,
will be
sir.
seen in TA1.
corkscrew appearance, site of block, extent of block, number of blocks, collaterals. Then one more important
Yes.
find you have to look for. What is that? That's the point you have to always mention in the discussion. That will be MCQ question also.
Yes, yes.
Distal runoff. Heard about it?
Distal runoff
Distal
will
runoff.
be seen, sir, before doing it to do the amputation.
What is distal runoff?
So the blood supply to the distal part of the thrombus present, sir.
Not thrombus, occlusion. Okay.
Any occlusion, sir.
Beyond the point of occlusion.
Yes,
The vessels.
Yes, sir.
Yeah. Filling of the dye or blood or perfusion distal to the obstruction. How much it fills.
Yes, sir.
If it is adequate or inadequate is very, very crucial point. If it is adequate, what it
Yes,
means?
sir.
If there is a good distal runoff in a CT angiogram,
There is compensation present, sir.
it is a compensated. It will be able to
It will
salvage,
be able to
save the limb.
Save the limb.
Save the limb.
You can do a bypass.
Yes.
Yeah. With the whatever the intervention. If it is very poor, inadequate distal runoff, it is less. It's a
There
decompensation.
is decompensation, sir.
It will less likely to save the limb. That's why distal
Yes.
runoff is very, very important to mention and look for in angiogram. Okay.
Yes, sir.
Sir, what you say?
First one, we can mention handheld Doppler, which is
Yes, sir.
available
Handheld Doppler will be used.
available in the bedside in most of the institutions.
Available in most of the hospitals. So you better to mention handheld Doppler. A non-invasive
Yes, sir.
handheld Doppler, then a V-board Doppler scan with the Doppler, like that. Otherwise,
Doppler, sir.
like
Let's
a
scan.
handheld Doppler and a V-board Doppler scan with the Doppler, like that you have to put. Because handheld Doppler is being available in most of the centers now. We can always do it, and your own you can find. You don't require any sonologist. Correct, no, sir?
Yes, sir.
Yes, sir.
So though you mentioned
Ultrasound will be seen.
non-invasive for CT, for MRI and DSA, you have to use some contrast.
That CT, all those become
It is a bit
invasive.
invasive.
They are not non-invasive. Only handheld Doppler, Doppler scan, ABPI only non-invasive. Other things are
Non-invasive.
invasive.
CT, MRI, you have to
Yes, sir.
use contrast. Understand? So you have to be very specific.
Yes, sir.
Because when you
So
come
they are invasive investigation. They are not.
later part of your investigations, we will tell you.
So
Yes.
better to not to mention this non-invasive word. Okay. Otherwise, you have to put
Yes, sir.
an invasive word here, because CT angiogram,
Yes,
like
sir.
sir rightly pointed out, they are invasive investigations, not non-invasive. Okay. Understood?
Yes, sir.
No, Hariharan.
Yes, sir.
Yes, sir. Yes, sir.
So that point
Yes, sir. I understand.
you have to rectify. Okay.
Because in a diseased vessel, if you do angiogram introducing a contrast, that itself may cause further
Will
damage.
exaggerate.
So you have to be very bizarre said about distal runoff. If the distal runoff vessels are very good, then you can do angiogram.
Angiogram. That's what.
That is
Yes, sir.
actually that is the principle. Understand?
Okay.
Okay. Proceed.
Yes, sir.
So next slide. So here X-ray foot you said. Why X-ray foot?
So to look for any osteomyelitis present in the bones. Sir.
Yeah, that is to assess extent of bone, not involvement of the bone, not extent.
Sequestrum.
Bone is osteomyelitis is there or not, you will check. Okay.
Why you do
Yes.
lipid profile?
So to find any dyslipidemia present or not, sir.
Why you want to know that?
What is the
But in
rationale?
case of dyslipidemia, there could be chances of atherosclerosis.
No, no. What is your case?
Atherosclerosis.
Case is due to atherosclerosis only, no? So you want to know.
Yes, sir.
So when you have hyper cholesterol and all the
Cholesterol will be.
control, why you do renal function test?
That's the
To
reason.
know whether there is any renal pathology.
So what you are going to do?
Obstruction in the embolism, which is
In case of
obstruction in the renal.
renal failure, there could be
Arterial flow,
hemodynamic imbalance. Sir.
artery to the kidney also may be affected. So renal impairment will be there.
Yes, sir.
So for that,
Renal artery stenosis will be there.
and we talked about CT and MRI angiogram. Understand? So when you give contrast with the patient who has got kidney problems, you cannot give.
Okay,
So CT angio and MRI angio, if you are planning, you should know the renal function must be normal.
Normal. Dye-induced nephropathy could be happening, sir.
Can you mention what dye is used for CT and MRI?
What is the dye used?
Sir, sodium trizoate, iohexol, and
Angiographin that contains sodium diaphragmate. Okay.
yes, sir.
And sir, like rightly told, see, you have put invasive again angiogram we have put here. You have put a non-invasive angiogram you have put invasive angiogram. So actually I also overlooked, sir has pointed out properly. So either don't use the word. If you are using that word, put it in the proper way. Don't get confused.
Yes, sir.
The X-ray of the foot, if there is a dead bone, what do you call it?
Yeah, that is a right term.
Sequestrum, sir.
Sequestrum, sir.
Sequestrum. Okay, sequestrum. Vascularity is that bone is necrosed, means you can see a healthy bone segment, part of the bone would have been necrosed. So you can see that in the X-ray very clearly. Yeah, that is one of the reasons for taking X-ray, plus nearby adjacent bones also may be involved because of ischemia. Okay.
So what is gangrene, Samir? Define gangrene.
Sir, cut off of the blood supply to the distal parts is called as gangrene, sir. Usually there are two types of gangrenes.
Define it.
One is
It's a macroscopic depth of tissue in situ
yes, sir.
with the putrefaction. Okay.
Yes, sir. Mummification of the tissues is
So that's due to loss of blood supply, but the definition is a macroscopic depth of tissue with the putrefaction in situ. Okay.
Yes,
All
sir.
these words should be there. Macroscopic depth of tissue in situ with the putrefaction. Due to loss of blood supply, you'll add on to later. It's not a cut off blood supply. That word should not use. We should have proper. We should put the proper definition words. Understood? Okay. So that's the gangrene. So we'll go to next slide. Sir, we'll go to next slide.
Yes, sir. Proceed.
Okay. So how will manage?
Medical management, pain control, opioid analgesics for severe pain is given, antiplatelet therapy, aspirin or clopidogrel to reduce the risk of further arterial thrombosis, diabetic control, strict control of diabetes mellitus using lifestyle modification and oral hypoglycemic agents should be given along with insulin. Lipid lowering agents like statin should be given to manage the hyperlipidemia. Antibiotics to control the infection and preventing the sepsis should be given. Next slide, please.
Next. Okay.
Can I ask you, sir?
Yes, sir. Please, sir.
Why, first one, why you want to control the pain? To relieve symptoms? Is there any other underlying mechanism?
The pain can accentuate the level of vasospasm present in RTD.
Remember that.
So we have to
spasm. Pain, spasm, pain.
Yes.
So that cycle has to be broken. Means you give relief not only symptomatically, vascular spasm can be overcome. So that will help in some amount of perfusion. Okay?
Improve the perfusion.
What type of drugs you use? Opioid.
Tramadols can be given, sir.
No, you remember you committed in rest pain means which is not relieved by conventional drugs. You said no.
Yes,
rest pain
morphine.
Yes, sir.
That's why you have to go for this kind of opioid analgesic.
Morphine, yes, sir.
That analgesics will relieve the pain as well as relieve the spasm. Understand?
Yes, sir.
Antiplatelet therapy. Why?
Sir,
Antiplatelet therapy.
It could cause thrombosis when there is already pre-existing conditions.
Okay.
So we have to reduce the platelet aggregation. So we have to give the clopidogrel and aspirin combination.
It also increases the microcirculation. So whatever this capillary is also involved with the disease, whatever left behind microcirculation may be increased. You know that angiosome complex, angiosome concept is there. So angiosomes will increase will get the more perfusion with these drugs. Understood? So some sort of a perfusion will be increased in the microcirculation. Everything is blocked there. Hypoxia is there. So may be able to increase the perfusion. So okay, lipid lowering agent already discussed. If there is infection, agreed. If it is so, do a culture and then to give antibiotic accepted. So next one. Next one.
Surgical management.
Okay.
Revascularization should be done on the basis of the digital subtraction angiography. Bypass grafting or endovascular intervention can be done in this case. Amputation at the appropriate level should be.
No. Listen.
1 minute.
Bypass grafting and endovascular intervention only if the distal runoff is
that is
right.
Present.
So most of the time revascularization is done with the conventional, especially endovascular stenting, whatever it is done with the conventional angiogram. they will be able to decide where exactly to put all those things. So, like right,
Using CM, we could
if
use the
there is good to distal run up only, all these things are possible. Otherwise, it is a
yes,
futile exercise. That point you have to remember. And reverse procedure, you have to remember profundoplasty and different arterial grafts, then saphenous vein graft, in situ, reverse. What are the meaning? What is profundoplasty? What is profundoplasty?
uh,
If you don't know, tell, don't know, no issues.
Samir, you know profundoplasty what is?
Sir, there will be reversing of the
Right. Common femoral artery is there. It continues as superficial femoral artery. Profunda femoral is
yes,
a
sir.
deep femoral artery. So at the junction, there will be commonly blockage. If there is a blockage
Yes,
at the junction, profunda femoris opening, then the entire collateral system is blocked. So in that opening, you make an incision, remove the thrombus. Then if requires, say, put a venous patch or graft, small graft patch, widen the opening of the ostium of the profunda femoris. That increases the entire collateral perfusion, will be able to salvage the limb. That is the idea. There is a simpler thing any general surgeon can do, technically very easier. And so that is the meaning of the profundoplasty. Very useful technique, especially there is a localized blockage. Understood? So you should know able to know. You should know the what is the meaning of profundoplasty. Other than that, you can do thrombectomy, removal of the thrombus. Endarterectomy is the removal of the thrombus with
and
the
artery can be
endothelium of the vessel. Understood? Then of course bypass grafts. In that you can do the saphenous vein graft in situ where you don't dissect it out, but you have to use a valvotomy and remove the walls. Why you want to remove the walls in in situ saphenous vein graft? Why you want to remove the wall?
we have to reverse the
reversing
right venous vein.
What you have to? Why you want to remove the wall? Reverse the blood. Otherwise, blood will not flow. Otherwise, you have to reverse the vein.
Valves will be
Yeah.
not useful if there
Because
is valve.
that wall will prevent the blood flow. So then,
Yes,
of course, you have to go to the graft. What graft you will use? What graft you will use?
PTFE grafts can be used.
Which one?
Polytetrafluoroethylene
Oh, PTF.
grafts can be used. Dacron grafts.
Dacron graft. PTF is different. Dacron is different.
Yes, sir.
Dacron graft will be used for the major vessel. Distal vessels you may
Yes,
use
sir.
PTF.
I too will use
Okay. So arterial substitutes may be asked as a short note, especially for postgraduate, I think, no, sir.
Yes, sir.
Arterial substitute. So postgraduate, they have to know Dacron graft, Owen graft, dictate graft, Weiler graft, all those things. So reverse saphenous vein graft, insert saphenous vein graft, meaning you should know. Profundoplasty meaning you should know. Okay. And you said amputation. In this patient, will you do amputation some level? Because you said great
yes,
point.
sir.
race operation can be done here, sir.
Ray amputation.
Yes, incision.
So, what is the
Incision.
meaning of ray amputation? Ray
Sir,
amputation.
from the level of demarcation, we'll cut off the limb around by 2 centimeters, sir.
No, ray amputation is removal of the entire head of the metatarsal. Metatarsal head should be removed.
The,
Usually leave the wound open, never suture the wound. Because if you suture the wound, again perfusion will be reduced, allow it to granulate on its own. Eventually, you can suture it if required. Okay. Head of the metatarsal should be removed. That is a very important point in the ray amputation. Okay. So different levels of amputations below knee, Symes amputation, you have to know. It may be asked in the exam. Okay, meaning of the below knee, Burgess operation, Gritty talks, above knee. Commonly done is ray amputation, below knee amputation, above knee amputation for vascular insufficiency. Another point you have to remember while doing amputation is never use tourniquet in vascular insufficiency patient because it will further damage whatever retained blood supply. So never use tourniquet when you're doing amputation in vascular insufficiency and diabetic gangrene. Okay, that point also you have to remember.
yes, sir.
Okay, of course, prevention you already written. Sir, anything to add, sir? Next slide, Shreya.
Yes, sir. Proceed, sir. You can proceed. I think.
Yes, sir.
Regarding etiology, for postgraduates, I would suggest polycythemia, they should remember.
Yeah, polycythemia you have to remember.
Peripheral vascular disease, that is one of the which increases the viscosity of the blood. Polycythemia also can precipitate.
And interestingly, sir, polycythemia is not uncommon.
Yes.
I have seen many patients polycythemia. So it is a polycythemia it's again more common in a smoker, sir.
Yes, sir. Smoker. Yes,
Right.
correct.
That also point important. I think that's a very good point you have to remember. Then, so conclusions are about their presentation. They presented fairly well, I think. They were had the discussion, of course, in a media like this, but they have intervened. They presented with the smallest some hurdles in between. Presentation is good, sir. Your opinion, sir?
Reasonable, sir. I won't say. I
Uh,
won't say very good only, but still,
no, sir. Good.
they managed to
They
present
managed to answer. They managed to get the
it.
reason. Here and there, some answers are made, but they eventually they could make up.
Yes, sir.
And the presentational charting also good. Some families and something left became temperature were not checked. Otherwise, overall it is a they presented well. Samir presented well. Hariharan both was presented well discussion. That is definitely good presentation. I will definitely truly
Yes,
appreciate
sir.
it.
Yes, sir.
At UG level, good.
PG level, it's good only, sir.
Level is good only.
Wish them all the best, sir.
Sir, I will go to my slide, sir.
Yes, sir. Yes, sir.
Yes, sir.
Thank you, Samir and
Thank you, Samir. Thank you, Hariharan. Well done.
Hariharan.
Definitely. It's the only discussion. Don't get demoralized. You answered so many things, okay? Everything you can't answer in the exam.
So
So
in
whatever
exam, peripheral vascular disease, I think both of them will do well. Maybe it's more
will do well, in the exam, they will do well if they get peripheral vascular disease.
Thank you, sir.
So I'll just go through the thing. Next slide, Leah. So I'll just go through whatever discussed there.
Yes.
It's common in lower limb arthritis is the commonest cause. TU to be kept in mind in young and middle-aged. And precipitating factors smoking, fallen, diabetes, hypertension. Family history are relevant because you should have economic backup. Limb salvage is possible prior to formation of gangrene. Remember, so don't allow these people to go for gangrene. Before that, you pick up this patient, and start treating so that you'll be able to save the limb. But it needs meticulous approach. That's very, very important. It's a multidisciplinary approach. Diabetic foot, gangrene, vascular insufficiency. Okay, that point you have to remember. Next slide. So history, this is the thing. Chief complaint, you write wise, main claudication, pain, ulcer, gangrene, color change, duration. I'm just going through that orderly. Just whatever you have written, presented, everything, same thing for everybody. Claudication, what's grading, you should know distance, different levels. Meaning of the claudication is pain appears during exercise and pain disappears when exercise stops. That's the definition. That point you have to remember. Then Leriche syndrome, you have to know impotency, iliac block, and maybe neurogenic venous, different meaning. You should know pain, rest pain type, size, severity, aggravating limb factor, change in the color, ulceration if it is there, gangrene, if the line of demarcation, mode of ulcer, duration, other history, fever, difficulty in walking, numbness, abdominal pain, chest pain, features of thrombophlebitis. Okay, next slide. And past history, similar treatment for the same drugs, evaluation, surgery if any undergone, treatment of cardiac disease, diabetes, past relevant trauma. And personal history, smoking, pan, and smoking index you have to remember. Years of smoking into number of cigarettes, pack area index, number of years of smoking, number of packets. That meanings you should know more than 300 smoking index and more than 40 packet index is dangerous. And family tree with the inlet details you have to ask. You have not written that. It's important. All long case, siblings of the patient, children, how many children patient is having, how many siblings the parents are having. The 3-generation family tree has to be written. Little economic backup also will come to know. If they had a major illness, major admission, major hospitalization of any of the family members, the details should be asked Samir and Hariharan. Next. So
Yes.
write brief summary of the issue always in case sheet which you have written already. Do not use short forms. Again, don't write HOPI, PI. All those short forms are not allowed to write in the exam. Don't ever write short forms. Full forms should be written. Of course, you have written full forms, but in the exam you tend to write HOPI. All those short forms in the exam don't write. So general exam, local exams, and all these things we already told. Both limbs are important. Comparison important. Signs of ischemia, color change, texture, edema, ulceration. Explain detail, gangrene. Detail it like a stent. Line of demarc is a very important definition. Swelling, edema, limb, skip lesions, and Burger postural threat, limb elevation. It is not necessary when there's a rest pain and gangrene, but you should know the meaning. Status of superficial veins, guttering of the vein, you already told. Capillary filling, venous refilling, you already told. Limb deformity, gait is important. Lymph node examination, you have to mention. Have you mentioned lymph node examination? In the lymph node has to be mentioned whether it is
Yes, sir. The
Yes,
lymph
sir, we
nodes were not
mentioned that.
palpable, sir.
okay. That is important. local rise of temperature, tenderness, muscle tenderness important. You understand? Edema, gangrene, capillary refilling, harvest refilling, palpation blood vessels from below upward. Don't try it from above downward. Below upward is important. And special tests I'm not discussing. Future like disappearing pulse, Burgess postural test, guttering of vein, Levis reactive hyperemia test, upper limb. Just to go through these things, you should know these things when they ask in the exam. Elevation arm test, Roos test, costo compression test, Adson test, Allen test, and supraclavicular fossa in the upper limb ischemia for cervical and assessment of wastage, limb girth and length, muscle power when needed. And trill, you are not auscultation. You are told femoral, renal, and subclavian carotid. Thrill, you have to palpate for thrill and auscultate for bruit. That suggests there is a stenosis when there is a thrill and bruit on auscultation. Okay. Next slide. Share next slide. Continue. So this is the orderly way you already written that order always from below upward, never right from above downward. Dorsal is posterior tibial, anterior tibial, popliteal, femoral, radial, ulnar. You should know over which bone you are palpating. Axillary subclavian. You know, carotid is palpated over the transverse fascia of C6 vertebra. In the book, it is mentioned Chaisagnate tubercle. Many put to debate on that how to feel Chaisagnate, although difficult, but at least anatomically you should remember it is palpated over the Chaisagnate tubercle, transverse fascia 6 cervical vertebra, and superficial temporal artery palpated over the zygomatic bone, not over the temporal. Okay, next slide. So note both upper lower limbs, right side, left side should be examined. Both sides, always both sides should be examined. Ask a femoral, renal, subclavian artery current from Brui, and regional lymph node, gait and joint movement that you have mentioned. Next slide. Abdomen examination for aneurysm, that's important, especially 65-year-old. Palpation of the aorta above the umbilicus. Aorta is in the umbilical level divides into common iliac arteries. So above the umbilicus, you have to palpate in the midline for pulsatile swelling, non-mobile, pulsatile, smooth swelling. Respiratory cardiac system, you have to mention. CNS examination, you have to mention, because diabetes, especially neuropathy, will be there. It's very common. So sensation, sense of position, and touch sensation. These are the things you have to examine. Next slide. So give complete diagnosis, like for example, gangrene right great toe with ischemic culture in the right sole with the critical limb ischemia due to atherosclerosis and diabetes mellitus. Like complete diagnosis you have to give, not you should not grumble. And these are the investigations you have to mention. X-ray part you are told to place B mode ultrasound study. Of course, hand-held Doppler you have to add on to already told. And invasive dynamic conventional CT gram DSA and TMT ECG echo is important because you have to assess the cardiac system. And of course, lipid profile blood that you have to, I will not detailed because you already mentioned that. Next slide. And treatment drugs, different drugs, all clopidogrel, salastrazole, PTA, surgical intervention already told, thrombectomy, endarterectomy, profundoplasty, saphenous vein graft, in situ reverse arterial graft. Indirect, now there is not much role when we are postgraduates. Lumbar sympathetic odontoplasty should be used to do. Other diabetes management, ulcer management, and amputation, different levels, ray amputation, below knee, above knee. This is also important. Next one. So this is rest pain, how to check. You see that? How to check rest pain. Dry gangrene is here. This skip lesion. These skip lesions are, you see that gangrene enter. This requires a here also skip lesion because they are above knee amputation. Upper limb ischemia, you have to, don't forget. It's a wet gangrene here. This is a dry gangrene here. So the skip lesions are very important. You have to mention skip lesions. Next slide. So and this is the X-ray showing osteomyelitis here. Osteomyelitis here. And angiogram. See that how exactly angiogram looks like. Here there is a block here, block here. Same thing, there is a block here. So this you should know how angiogram looks like. And features of severe ischemia are already discussed. And this is classified large artery occlusion, small artery occlusion, atherosclerosis, EAO. Angiogram findings look for, I already told, distal runoff, corpus appearance, blockage, proximal and so on, and chronic or acute diseases, anticoagulant therapy, how to palpate the pulse is very, very important. Remember, distal to proximal, already discussed. Which bone, over which bone it is palpated, you should remember it to be asked in the exam. Next slide. So, treatment aspect we will not discuss. We are already discussed, already discussed, and all of you know my book,
Camera.
operative book, clinical book with the video and website. All of you are joined, and request everybody to join my website. Daily lectures are there. So briefly, I have told, sir, Sir, you can add on to anything. This is sufficient for UGs and even for PGs. And little more detail about atherosclerosis should know. Then treatment aspect, technical aspect, PGs should know, sir.
Yes, sir. For short of time,
Yes, sir.
level of occlusion can be made by clinical science. That part we never discussed. Like pain over the thigh in the gluteal region.
Okay. So
And things that is one thing. Second thing, by concluding to say amputation, before just they say amputation or whatever type, they should see that the vascularity that must be improved in all levels, right, medically or surgically, before planning for amputation. Otherwise, straight away go for amputation, definitely the level of amputation is going to be revised subsequently.
Yes, sir.
That's two things I would like to.
That's a point. Yes, sir. Yes, sir. So next, let's Shreya, next. This is my website. All of you are requested to join that. So Shreya, next slide. So that's it. So that is the conclusion. Divya, you are there, Divya. So Divya is not there. Hello, Divya. So, sir, I think most of the things we have covered. It's a very commonly kept a long case in the exam, both UG and PG. So, basic clinical exams is very important, palpation, everything.
Yes, sir.
So, I thank you very much, sir. If anything to add on, to please add on.
No, sir. Thank you for giving this opportunity.
Well, and your presence made my live session, our live session, more vibrant.
Yes, sir.
And, students, of course, Hariharan and Samir, thank you very much for presenting. They presented well, sir, actually. UG level, definitely.
Definitely.
No debate. And Divya? Hello, Divya.
Yes, sir. Good evening, sir. Good evening, sir.
Vote of thanks. Divya will give the vote of thanks.
Yes.
He's a surgeon in Gujarat. He was my student earlier.
Yes,
He was working with me for more than 6 years, sir. Divya, give a concluding remark.
Thank you, sir. Thank you. On behalf of good evening all, one respected Manoharan sir. So on behalf of our organizing team, it's my privilege to propose vote of thanks with a lot of gratitude and respect for our today's guest, Dr. V Manoharan sir, and our Dr. SRB sir. So giving his valuable time for today's talk. I thank you, sir, for your valuable knowledge and enlightening all of us for our today's live session on PVD. And I also thank today's presenters Samir Nanda and Hariharan for giving his idea about today's case. And with this note, we conclude today's live session on PVD. Before saying goodbye, we please share, like, and subscribe our SRB Surgical Insight and stay updated with daily surgical videos. Thank you, sir. Thank you, Manoharan sir.
Okay. And last one is the next week we'll have a discussion on the examination of varicose vein. Request sir, all students to join. Hariharan and Samir, ask your all batchmate to join for varicose vein discussion also.
So we will also join, sir.
Yes, sir. Please, definitely join, sir. I'll send the link. You can, whenever if you are free, definitely join and give your comments and your knowledge to that. Because varicose vein again very important for the exam. They'll keep a long case. So Samir, Hariharan, join next week also. Same time, 7
Definitely, sir.
Tell you for this one. You have presented well. Everything we have covered, I think, sir.
Yes, sir. Yes, sir.
Yes, sir.
Thank you very much for spending 1.5 hours with me. Sorry, I apologize for your, making you to have stayed longer time.
It's a pleasure.
Sir,
Pleasure
no,
listening.
sir.
Pleasure listening.
Pleasure.
No, sir. We are privileged to have present this case on behalf of you, sir.
Yes, Samir. Thank you, Hariharan. Thank you, sir. We'll conclude, sir. Thank you very much
Thank you
for
so much,
joining. Divya, thank you, Hariharan,
Thank you,
thank you, Samir.
Thank you, sir.
Thank you so
Good
much.
night, sir. Thank you, sir.
Thank you, sir.
Jaya and Shashank, Shubhank and Aditya, my IT team who have organized these things very well, sir.
Yes,
I really congratulate them because they have never in communicate with you and the students for all these needed things. They have done whatever background work is done by them.
Yes, sir.
Joined and did, sir. Thank you very much, sir.
Thank you, sir. Thank you, sir.
Thank you very much, sir.
Thank you, sir.
Messages daily, sir. Thank you, sir.
Yes, sir.
Thank you.
Thank you, sir.
Thank you, Divya. Thank you very much.
Thank you,
Thank you
sir.
so
Thank
much,
you.
sir.